Welcome to the PerfWeb podcast, hosted by Joe Basha.
And good morning, everyone. I'm your host, Joe Basha of PerfWeb, and I'm here today with Juan Navarrete, my new best friend, because him and his beautiful wife, Mindy, have joined us here at HET. And today he told me, well, his wife actually told me that Juan loves doing these kinds of programs. So I invited him today. He was going to come just watch, but I said, no, just get a microphone and come up here and sit down and be a part of this and, you know, and critique whatever it is I'm about to say today. But it's going to be a really good program. We're going to start off with the physiology of CPB, or the anti-physiology of CPB, I think is what Juan had called it. And then we're going to follow that up with the intra-aortic balloon pump for perfusionists, and then we're going to go into a program or a lecture that I hadn't heard yet. It was apparently given at AMSECT. Magic, our technical director over there, is who found these folks. They're from Spain, and they're going to be talking about I guess AI and gamification for perfusion simulations. But listen, let me introduce Juan a little more formally. So Juan is Cuban born, came here when he was 7 years old. He was working in an ER as what was then referred to as orderlies, and now known as PCAs, or patient care assistants. And he showed an interest and aptitude for a lot of different things. And in 1986, he graduated from the Newark Beth Israel Perfusion program. It was headed by Dennis Fox. Then he went and worked at George Washington University, where he ultimately became chief of that program, and then later on moved to Tidewater, Virginia, and worked with the surgeon, Paul Evans, that Juan says is the best surgeon, that best fellow and best surgeon, best person he ever knew. Now, you know, here in Houston, here up in the Woodlands, we've got a couple of really good guys, you know, like Devinder Bhatia. How much nicer could you possibly be besides him?
Well, I'm hoping that I'll get the chance to find out.
Yes. So I gave kind of the formalized version, just sort of chronology of that kind of stuff. But you do have an interesting story about how you got into perfusion. Share it with our audience.
Well, some of you probably remember Aaron Hill. He was the chief of perfusion at Fairfax Hospital, Texas Heart grad. He was also the president of the American Academy, you know, very involved in research. But when I first met him, I was, as I said, an orderly in the ER. And my job in the morning basically was to come in and wipe down every flat surface with disinfectant. This one particular morning, they had a patient come into the room, and they said they need you to do CPR in room 8, I think it was. So I put down my bucket. I hadn't really had enough coffee yet, but I go in and start doing CPR on the patient. And you would get his blood pressure up. He would try to push you off his chest, mouthing the word stop, it hurts. You'd stop CPR, his blood pressure would fall out, and he'd, you know, become unconscious. The ER docs worked on him for about 45 minutes. Then the CCU residents started coming into the building, and they came in to offer what they could. Eventually, cardiology started coming in, and they managed the patient for an additional 45 minutes. And by this point, he was blue, dusky. He was no longer, you know, we had intubated him. He'd been paralyzed, so he wasn't trying to get off the stretcher and go home. But they finally called the cardiac surgery team. They were in the OR, had a patient on the table, but they brought the heart-lung machine down, and they put the patient on fem-fem bypass. And the patient went from being this dusky cyanotic blue to being rosy red and pink. And I looked at the machine and I said, that's kind of neat. I'd like to learn to do that. So we had the opportunity to work with Aaron Hill and Bob Groom.
Bob Groom, man, he's a good guy.
Yeah, he was one of three at that time. Bob Vanansky, I want to say, was the third perfusionist, a great group. They worked closely with the Fairfax Hospital School of Life Support Technology. They brought us into the OR, into the cath lab. We learned balloon pumping and monitoring, and that eventually led me to Newark Beth Israel. I had a good background and a good letter of recommendation from someone who had a little pull in the industry at the time. Miss Aaron, he's gone now, but contributed a great deal to our profession.
Yes,
good guy.
Yeah, him, Charlie. I mean, all those guys. They were incredible. I met him. I only met Aaron, I think, 3 or 4 times over the course of my career. Last time was probably, I don't know, 10 years ago, maybe. I guess it was somewhere in Wyoming at a meeting up there. So, but real interesting character. Definitely an interesting character. Really, I mean, one of the giants, I think, in perfusion. We talk about the giants of cardiac surgery all the time, the Coolies and the DeBakey's and all these guys. But Charlie and Aaron were right there, with that as well. And a lot of good folks that laid the foundation for us. Absolutely. And you brought up balloon pumping because that's going to be my second lecture. I was telling Juan earlier today. This morning while we were waiting to go live on the air, that it's amazing to me how many perfusionists, younger perfusionists, I should say, more accurately, have no idea how to run a balloon pump or what it actually is doing, where it's even placed, what its function is, and how you time it. I find that interesting because that was such a common thing for us.
Yeah, the physiology and the engineering of the balloon pump is really remarkably well-founded, and it was a tool that saved a lot of lives.
Yes.
We've moved into different modalities now, and one can argue, which one is best. But I think balloon pumps still have a huge role, not only post cardiac surgery, but certainly getting someone to cardiac surgery.
Absolutely. Absolutely. Yeah. I mean, I think that it's kind of like the kitchen sink, right? Theory is if you have a patient that has unstable angina and you need to cool them off a little bit and they need to wait a couple of days, and the balloon pump helps to relieve that problem, it's easier to place, much more affordable, works very, very well, less risks, less associated morbidities, and instead of going to an Impella immediately, which is kind of throwing this kitchen sink at somebody that may not need that. You don't have LV failure, you have ischemia, and you need to manage that.
Yeah, we would tune people up for a couple of days of instead of the Friday evening emergency, you could put in a balloon pump and stabilize them, get them so that they're not, urgent. And then on Monday morning, you would go ahead and operate and do a definitive revascularization.
Yeah, absolutely. We'll go from emergent to an urgent, because if you're going to keep them, cool them off for the weekend, they downgrade a little bit, right? From this, we got to do it right now, to we can do it in a much more controlled way.
Another thing that was happening in Virginia, and I don't know if this is a nationwide phenomenon, but if they put a patient on an Impella, that patient would no longer be on the cardiac transplant list.
Really?
They would sort of get demoted down because they were considered less clinically, urgent, and could be kept on pump. So that was an interesting practice that they did in the center part of the state. I won't.
I didn't know that. I didn't realize that. Oh, it's interesting. That's really interesting. We need to look more into that, because that seems unreasonable to me. But you just, there's a paucity of organs compared to the number of organs needed.
Yep.
Right. So anything that can be done to put an organ in somebody else makes more sense. It's just a reality. of the problem.
And I think that's their thinking is, this guy is going to be fine for a while.
Yep. Let's give that organ to somebody else who may not be eligible for this. That's a good point. Okay, so we're going to dive in to the my first lecture. Now, the way I like to do these, since you've never done this with me, is if I say something, in the middle of saying it, it can be somebody from online, Magical, let us know. If anybody or you see something, you need additional clarification, something doesn't make sense, you think something is wrong, just interrupt me. Okay, it's kind of an informal, freewheeling kind of process. Okay. So make it enjoyable and make it more of a conversation than just a straight line lecture, which, everybody out there that's watching is generally an experienced perfusionist, has some idea of what's going on. So the physiology of CPB. So what are we trying to do? So here are the, major human organs, and the ones that we really focus on is obviously the brain and the heart and the kidneys, to some degree, lesser degree, the lungs, and really all we want to make sure we do is we don't have a infarct of the gut or whatever, but really it's heart, kidneys, brain, lungs. The stomach, I don't think I've ever taken the stomach into consideration one time in anything we do from our perspective, right? So what are some of the cardiac surgery risks and complications? And you'll find that these numbers are very wide. The range is big. And a lot of that has to do with it's not defining what kind of case. These are all comers. So it can be a simple single vessel CABG all the way up to a triple valve 5-vessel CABG with a Bentall on top of it. So bleeding somewhere between 2 and 8%, infection 0.2 to 8%, stroke, and this is stroke being defined as a stroke, a permanent stroke, not one of those, kind of ambiguous, grandpa just isn't the same anymore. 1.3 to 5%, MI 0.5 to 10%, renal failure requiring IHD 0.3 to 10%, which is huge, really, when you think about it, because I'm going to be talking quite a bit about the kidneys and renal failure during cardiac surgery, CSA AKI, cardiac surgery associated acute kidney injury and failure. AKI rates much higher, 20 to 30%. It's very common. And it's surprising to me, given how long we've been doing this, how common renal failure is and how we have yet to really find a good solution to that problem. It pervades as a very common problem. Death is 0.2 to 7.7%. And then you have these other things, prolonged ventilation, prolonged ICU length of stay, and these are the definitions, greater than 12 hours, greater than 3 days, and prolonged stay in the hospital, which is greater than 10 days. And the source for this was the STS. So here's your team, the group of perfusionists. We're all sitting around, and I kept the pressure at 50 the whole case, because that's where the surgeon wants it. The surgeon wants the pressure at 50 the whole case, and everybody's toasting, everybody's happy. You did a great case. And then, of course, you get the person who asks, and this could be either one talking. So the male could be the perfusionist, the female could be the perfusionist, doesn't matter which. So what do you do for work? I'm a perfusionist. Oh, what's that? The answer, I maintain the patient's normal physiology during open heart surgery with the use of the cardiopulmonary bypass machine. Wow, that sounds impressive. That's really impressive. And you can see here that one of the two of them is impressed with the other. So what do we do in reality? Well, we take away the pulse almost entirely, if not entirely. Or we pretend our pump is generating a physiologic pressure of sorts. and at what cost. We have hypotension, sometimes for extended periods of time. We have acute severe hemodilution, sometimes more severe than others, and I realize that's subject to interpretation. In fact, Magic, when you get a chance, pull that comment up, because I do want to talk with Juan about, remember that comment that somebody made about my blood transfusion risk that you showed me? You had to approve it. Yeah, no, I don't need it right this second. I'll get it at the end of the lecture. Because I do want to address that. I forgot about that. So acute severe hypovolemic shock syndrome, because what do we do when we go on bypass? We open the venous line and we completely empty the heart. Well, the heart's gonna send out a bunch of signals. All the baroreceptors are gonna send out a bunch of signals going, what the hell has just happened? And then to make matters worse, we're gonna start pumping because we don't mix. Remember the old days of mixing? Where you'd take a little venous and add a little arterial, take a little venous until your pump was completely full of blood, and then you would go on bypass. Now, I know there's wrapping technique that can be used and stuff to maybe accomplish the same thing, but that's a different subject. I'm very anti-wrap. I think wrapping should be left to, Tupac and Biggie Smalls and Snoop D-O double G. That's who should be rapping. We should not be rapping. I don't believe it. I fundamentally think it's an absolutely ridiculous thing to do. However, with that said, you have that. And then so as you go on bypass, you have all this crystalloid going in, and the baroreceptors are now seeing that. So you have the chemoreceptors. So you have baroreceptors that are going, what the hell's going on? You have chemoreceptors saying, what the hell is going on? It's not surprising when your initial phase of going on bypass, though it's to some degree stable, it's anything but physiologic. It's completely foreign to what's going on with the body at that time. You have significantly reduced DO2 in the early phases of your initiation of bypass. You have to generate a higher line pressure to accommodate the lower DO2 because of dilution, so now you have to flow more. You expose the blood to a large foreign surface contact area over and over again, which is going to initiate an inflammatory cascade. And then, of course, some of that is evidenced by the frequent need for pressors. That's mostly as a result of an inflammatory mediated response. You expose blood to a very hostile pressure environment. There's a blood-air interface with the pump suckers. And you introduce air everywhere it was never meant to be. Can you see that? Or
I can see it better over there, actually.
You can see better. You can look at mine too if you want, if it's better for you. So what do I really do? So if somebody were to ask me, who was not a non-medical person, but an actual medical person that had some knowledge, how would I answer the question, what is it that I really do?
So my usual answer, and I don't know if I'm going to get myself into trouble, I tell people that I pump and suck for the almighty buck.
Yeah, well, that's true. I do like that. That is true. That's not what's on here. It's a little more sophisticated, a little more. So I mitigate to the best of my ability the harm I know I am going to cause. I'm there to facilitate a procedure that needs to be done on an organ system. But in order to do that, I have to cause harm. To what degree that harm I cause depends on a whole variety of factors. And my job is to mitigate that to the best of my ability. That's my viewpoint on what it is perfusionists do. So I showed you this earlier. I just put it up there just to remind you so you could kind of just peruse it real quickly and have it in your head, because I'm going to reference this a lot as we move forward. So here's the STS annual reports. And I wanted to show you a couple of things on this. So if you look here, the total procedure count from 2010 to 2021 has kind of gone up a little bit and then gone down, but it's mostly been, I would say, stable. The isolated cabbage count, you see it went down a little bit, it kind of recovered some, and it too is, we had a low year this year, but it has stayed fairly stable over the past, 11 years of this report. Now, interestingly enough, and I'll show you this a little bit more, the on-pump cases actually went up, and if you look, the off-pump cases, I'm going to address this a little bit more a little later, have actually gone down. The drop really started around 2017, maybe 2016, and continued to drop. Now here it's a little higher, but your total case count actually went up. So keep that in mind. And then it goes through like AVR. You can see the isolated AVR procedures have gone down quite a bit once they started doing TAVRs in the moderate risk group patients. When it was only high risk group, it really didn't see much of a drop. But then all of a sudden you do see it dropping here, and that's the reason for that. Okay. And here is that same, this is from the 2020 report, your STS mortality. So for isolated cabbage, again, these are not isolated cabbages with patients that have ejection fractions of 45 or 50%. These are all comers, and you have to always keep that in perspective when you look at these numbers. They're not drilled down to all the different subsets that you can get to. But 2.1%, that's in hospital. If you didn't die in the OR, if you died in the OR, you were here, that was a 2.7% mortality. Of the major morbidities, permanent stroke, this is just isolated cabbage, 1.5, renal failure at 2.3%, and then these other metrics here. Now let's look at MVR or double valves in hospital mortality, 9%, 10% in the operative mortality, or the intraoperative mortality. Permanent stroke, 3.1%. Renal failure, 9%. So the highest one was actually over here, MVR plus cabbage at 10%. Interestingly enough, MVR repair is a little bit better on a lot of these things for the MVR repair and cabbage, but the MVR repair actually has really pretty good numbers. The in-hospital mortality is lower than that of isolated cabbage, and the operative mortality as well. I found that very interesting. So we're going to go through all the different things that we discussed from this slide here. I'm just going to go down in order, okay? So bleeding. Bleeding is either going to be mechanical or it's going to be coagulopathic. It's going to be medical bleeding. And the mechanical bleeding, we all know what that is. That's prolinemia. We can't fix that. We're not responsible for that. Though they could argue we are if we're not able to give them a dry enough field. But that could be for a variety of reasons that may not be our fault, but we're not solving the problem either. It's usually inflammatory stimulated. You could have liver dysfunction. It could be dilutional, excessive self-saver post-blood processing. And I'll explain why I say that. So over here in this box, if you had 1,000 mLs, 1,000 mLs in the pump with a hematocrit of 20%, the patient had 5,000 cc's, their blood volume, also 20%. Your total red cell volume is 1,200. If we were to reduce with ultrafiltration the volume in the leftover pump circuit down to 240, you would have a post-hemofilter red cell volume of 240 cc's. And if you do the math on this, which I did, and you transfuse that via the pump, your new hematocrit would be 23%. That's a very big change. And if it makes that big a change on the smallest volume of the solid material in blood, imagine how many plasma proteins and platelets you are throwing away when you process all of that blood in the cell saver. So I'm a very big proponent of coming off bypass with the least amount of volume in the reservoir I need to safely manage the termination of the weaning process, get off of bypass, and whatever volume I have left in the reservoir, I hemoconcentrate it down to the lowest level I can so I'm not entraining air, and then I flush and pump all of the blood back into the patient. At that point, if the patient is still not tanked, I've given you some room because you got a good hemoglobin. You could give some albumin or you could give some more volume if you need to. But most of the time, this process in our practice, and every practice is different. You can't say what works here works there because some places have very restrictive fluid administration by anesthesia. We don't. We have very liberal. And so you have to look at your total practice. Does your surgeon suck out the left chest full of diluted material and fill your reservoir up with this colored Kool-Aid or not even Kool-Aid, vitamin water? And now all of a sudden your hematocrit falls. What do you do with that volume? Just come off bypass and pump it to the cell saver? Yeah, sure, you can give them a good crit, but you're taking away the value of hemoconcentration. What's your thoughts on that?
So, the best hemoconcentrator, of course, is the patient. If you can put we would often drop the legs, put that residual pump volume into the patient. The pump still remains primed with a crystalloid blood, but mostly crystalloid. Then decannulate, then slowly work the legs back towards level. Sure. If your patient is making good urine, that's probably the best way to preserve all of the, blood components.
Well, of course, that's one of the biggest challenges is urine output on cardiopulmonary bypass. And there's a whole lot of reasons why we don't have it. Okay, perfect. Thank you. So infection, well, that's a problem that happens with a variety of things. We're not talking deep sternal wound infections. That's a totally different animal, but we can certainly help with that, with helping to maintain the sugars normal and stuff. But if they get an inoculation of something in their sternum and they get a deep sternal wound infection, that's a different issue. But basically, just regular infections. As long as we're careful, we clean our connectors. When we're drawing up drugs, you use an alcohol wipe, drawing lab samples, trying not to contaminate your ports, managing the blood sugar, and avoid microvascular flow derangements as a result of these hyperglycemic issues. So that's why we control these sugars.
Have you seen where the anesthesia folks are now giving them like a big bottle of Gatorade to drink pre-surgery?
No.
For post-operative nausea and vomiting, and so we're very concerned about managing our sugars intraoperatively, but one of the newer protocols in anesthesia is actually giving them a big bump of a glucose solution prior to surgery.
Really?
We were doing that in Virginia, and it's in the anesthesia literature, and I was always a little unsure about, what the right hand is doing versus what the left hand is doing, but.
Well, we do live in silos.
Yes.
And that's something I think is also an issue, which I don't address in this lecture, but it's a very good point you bring up, is that we do operate in silos. And the concept of the heart care team is really, it's cliche. It's a great phrase, but is it really in practice? At some places, yes. And I will tell you that I know some places like that. We had a young lady here, I can't remember her name now, and she gave a lecture. She was an anti-rapper as well, and she gave a lecture and just did an incredible job on it. But she talked about their team cohesion and how they all work together towards these goals, and how they meet about them, they discuss them, there's a plan, and their outcomes are remarkable. I mean, they really are. And I think that the idea is a great idea, but it's really not in practice many places. Most places, we all kind of do our own thing. We're like the Sesame Street kids, all of us. Stroke. So there's stroke versus stroke. So this is atheroma and plaque in the aorta. There could be air and GME, could be from hypoperfusion, could be from very low CO2 and poor cerebral perfusion in that regard, low flow, low pressure, outflow obstruction from the heart being torqued over, cerebral oximetry, something very important to use. I have it down here, and also transcranial Doppler. If you had that, I think that's really one of the that was Bob Groom. Bob Groom talked about transcranial Doppler, and I remember I've said this on the program, I don't know, many times. He talked about, I used to think, oh, that guy's crazy. You know, what will you do that for? Bob, come on, we're not going to do TCD. But the more I learned about it, 10 years later, he was right. He was way ahead of the curve. We should really be using TCD on bypass. I think it really does make a difference. Temperature management, of course, very important, can affect stroke. Severe third spacing and edema can affect stroke with increased intracranial pressures. And of course, there's the grandpa or grandma just isn't themselves. That's the stroke versus stroke. There's these subtle changes that can occur, and people just seem different. They know we could really put their finger on it, but then there's the other, which is the overt stroke, the hemiparesis, you can't drink. What was you dribbling soup? Remember that? Your patient's going to be dribbling soup.
Yeah,
you stroke them out. Remember that?
The Q sign.
The Q sign, yes. The dotted Q?
Mm-mm.
That's when the fly lands on the tip of the tongue. So there's the O sign, which is your mouth is open. Then there's the Q sign, your mouth is open and your tongue's hanging out. And the worst one is the dotted Q, which is your mouth is open, tongue's hanging out, and there's a fly that's landed on it. That's usually portends a bad outcome. So I thought this article was very, very interesting. It's fairly contemporary, 2018, defining an intraoperative hypotension threshold in association with stroke in cardiac surgery. And here they show mean arterial pressure less than 65 for 10 or more minutes during cardiopulmonary bypass is associated with an increased risk of stroke. I can tell you, there's a lot of cases I do where I'm under 65 for more than 10 minutes. That's not that uncommon.
No.
We're struggling with it, but I think that our threshold, I'm going to talk a little bit about this as we move forward, is too low on what our mean arterial pressures are, because normal mean arterial pressure is about 92.
I haven't seen this study, so I'm curious how they corrected for, hematocrit, flow. I was asked as a witness on a case where the contention was that grandma's pressure had been at 45 for a long time. And I reviewed the chart, and it turned out that the flow had also been quite reduced, and the hematocrit was quite reduced. So if anything, the contention that the plaintiffs were making was, fine as far as it went, but it really had to do with a combination of things.
Yes.
I've always struggled between what is the appropriate flow to pressure. When your surgeon needs to see what he's sewing and your pressure's so high,
That should not matter. Now, it does matter in terms of the clamp slipping or leaking. Other reasons why it matters.
Non-coronary blood flow can be...
That's flow. That's not necessarily pressure. We can talk about that. And that's a good point. But I'm telling you, even the kidneys do not like hypotension at all. And so we accept it, but we'll go back to the beginning, which is, what do we do? We're talking about goal-directed perfusion. We're talking about maintaining normal physiology in a very abnormal environment and mitigating, ultimately, in my view, my statement is mitigating the harm I know I'm going to cause. And that, running a pressure of 45, notwithstanding flow, is on its own merits, deleterious to both the brain and the kidneys. We'll dive deeper into it. Perioperative MI, I mean, there's really not a whole lot we can be responsible for on that, although you helped me the other day to keep from me having a problem. You have emboli from doing the, arteriotomy when they're doing the anastomoses. Anything can happen. Trash gets down there or air. It could be a poor anastomosis. We can't really control that unless they can't see. Poor myocardial protection. It could be you didn't have the flow high enough, you had your vent on too high, or at all. You had you didn't have enough potassium in it. You didn't give it long enough. It wasn't cold enough. If you give cold, because we used to give warm bleach too. I mean, there's a myriad of reasons why that could be an issue. But how high should the root pressure be? How much disease do they have? Do they have AI? Are you losing some of the volume down there? Should we be using retrograde? Do we need to make sure we go down all the vein grafts to get past wherever the blockages are? There's so many questions. And then the Plegisol versus Delnito. Delnito was not made for adult cardiac surgery, but we do it for coronaries all the time. And that's not what its intended use was. It works most of the time, but you have got to get uniform distribution throughout the entire myocardium, or you will have a problem because you give no subsequent doses, and it can be a real problem. Now, if the heart's quiet, is that really the appropriate surrogate, the only surrogate, that it all got in? Now, listen, I've seen stone heart happen 2 times, where I had not seen it for 30 years. Saw it 2 times. Both times was, and it's more contemporary times, it was Delnito being used on cabbages. So I hadn't seen stone heart for 30 years. I've seen it twice, both times Delnito. So let's talk a little bit about acute kidney injury following cardiopulmonary bypass. It's a challenging picture. In this particular study, they went through a database and looked at everything, and this is what they have come up with. And the ones that I need you to focus on, of course, age is an independent risk. Being female is an independent risk. Smokers, LV ejection fraction of less than 35%, congenital heart disease, EGFR is an independent if they already have some element of CKD. If their serum creatinine is greater than 2.5 already, certainly an independent risk factor. You could have genetic markers, hemoglobin of less than 9. You have no, in fact, this comment that I'm going to address in a little bit, you have no idea how many people accept 7, hemoglobins of 7, and their patients by and large do fine. The data doesn't say it's good. So, I'm challenged by these things because I know we're going to get into the DO2 concept here in just a minute, but a hemoglobin of 9 versus a hemoglobin of 7 is a lot of arterial oxygen content. It's a lot. And so we need to discuss that, I think, a little bit further. Oxygen delivery, so low oxygen delivery, it says increasing oxygen delivery may be protective. I think it probably is. During 24-hour, if you have exposure to the contrast agent and surgery duration, okay, are all risk factors for developing acute kidney injury. So this was a very good statement from this article that was written, and again, this is relatively contemporary. It had to do with valve surgery. Cardiac surgery associated AKI, CSA AKI, is a severe complication, one of the strongest risk factors for mortality in patients after cardiac surgery, with an incidence varying from 8.9 to 42.5% according to the intricacy or complexity of the operation. And that's something you always have to keep in mind. In its more severe form, it boosts the likelihood of death by 50 to 80%. So you have acute renal failure, not AKI, acute renal failure with the need for dialysis post-surgery, and you weren't already a dialysis patient, your risk of dying goes up very, very high. Even a mild raise in serum creatinine after cardiac surgery can lead to a higher morbidity, as well as longer term of stay in both the hospital and the ICU, and of course that results in a higher cost. So here is their data, and the one that I highlighted, we won't go through all of these various different things. You can look at them at your leisure, but if you're, so this is total. This is cardiac surgery associated AKI here, and if they were free of AKI. And what you'll notice is there is an improvement if you kept your DO2 above 322.2 on average and 323. So at start and end. If you were down below 300, you had a much higher risk, in fact, statistically significant risk of developing cardiac surgery associated AKI. So they're higher in this study than what we are sort of striving for right now, which I think is a 272 number. We'll get into that particular study in the next few slides. So here they were saying less than 295, you're at risk. Less than 3, and your index needed if it was less than 303. So if this is a better number than this number, basically, and this is a CART analysis. It's a cutoff value classification and regression tree analysis. It really, all it's telling you is that anything under 295, you're at higher risk, and anything under 303, you're still at risk, because that is not even close to a normal. Your baseline DO2 is much higher than either of these numbers, and we can calculate that out. And what you see here is on your DO2 index, this number here, as you get to this point. This is 300, this is 325, so in that range, you start seeing this increase in your probability of developing acute kidney injury. Also here, the same thing. If you look here, you come back, you're in this 325, 20 range, and now you see you start increasing your risk of developing AKI as a result of inadequate oxygen delivery to the kidneys. And there is a real reason for that. You know, when you look at the kidney, the cortex of the kidney is running a PO2 of around 50. But when you get to the outer medulla of the kidney, your PO2 is around 20. So the kidneys are very high extraction of oxygen and very sensitive to decrease in O2 delivery because they're really using it a lot. There's a lot of energy being utilized by the kidneys. That's why they're 20% of our cardiac output. It's more than our brain. So it's a remarkable amount. This is out of Australia and New Zealand, and they go through these progression of looking at all of these records. I'll just leave that to be, but here's the bottom line of it when you look at it. So without AKI and with AKI, we talked about age, so you're going to have a higher percentage risk of getting AKI, and that's statistically significant. Diabetes is a factor. Cardiopulmonary bypass time is a factor. And minimum hemoglobin is a factor. And red cell transfusion is a factor. So you're damned if you do, damned if you don't, right? I can't, but I think that's where ultrafiltration really helps. You can maybe, but you know, you may be sacrificing flow, because you don't have volume, for oxygen carrying capacity. And it's a it's a very delicate balance. And I don't know that we have a really firm grasp on this.
Yeah, usually you know, when you're talking about multifactorial analyses, you can perhaps optimize two things, but you're often sacrificing the third. Flow, pressure, oxygen carrying capacity. You know, it's one thing to, I was lucky enough to work at the Veterans Hospital where every patient was a big, robust guy that brought a lot of volume into the OR with him. When you're working in a community that has little old, frail folks, it's often a real challenge to keep their carrying capacity at a level that's where you would like it to be.
Absolutely.
And then they tell you, you know, well, if you give blood, the patients do worse.
Yes.
But the patients who need the blood are going to be the ones that are going to do worse anyway.
This is true.
So, you know,
is it the blood, or if you don't give the blood? I mean, yes, it is very, very challenging. There's no question about it. So here we see this graph here and this graph here on all AKI risk and AKI injury. And the circles, the blue circles, are sensitivity, and specificity are the red squares. And you see somewhere in this area here, 270. This is where the 270 comes from. You have you lessen the risk of cardiac surgery associated, cardiopulmonary bypass associated acute kidney injury. Okay, so here you see less than 270, you had a higher risk than if you were equal or greater than 270 for risk, and then on the injury as well. Less than 270 is higher than the equal to or greater than 270. Now, maybe it's because we're not pulsing the patient. Maybe that's the reason. Answered? Thank you. Maybe that's the reason. So this is a very interesting study on flow, pulsatile flow. And these folks actually started their study with a new device that generated a truly, what they believed, physiologic pulse. And their goal was for them to sell this device, right? So they had a vested interest in their project actually working. So group one is physiological pulsatile flow with the new pulsatile ECC extracorporeal circulation pump system. Group two, conventional pulsatile flow by roller pump. And group three is non-pulsatile flow, also using a roller pump. So what you see here is the before. This is the pig, right? It was pigs, right? I believe it was pigs. Yes, domestic pigs. So here you see their regular physiologic pulse. Group one is what they saw as a pulse that mimicked the physiologic pulse. Group two is, remember, the pulsatile pump, pulsatility with the roller pump, going fast, slowing, or stopping fast, so forth. And then this is just continuous flow on the roller pump itself. And when you look at the pulse pressures, the before and on ECC with this pump, this new pump that they were developing, you can see they have good pulse pressure. Group one here, that's their thing. Pulse group two, really not much of a pulse pressure, and group three, literally none. Over here, you have peak aortic flow, and you see that the peak aortic flow in group one, using the baseline is the black, and the gray is on ECC. Group one is with their pump, and you can see that it's matching. Group B, it's not matching, and Group C, it's essentially the same as Group 2, right? And then over here, you have the DPTT, so the diastolic pressure, diastolic time. It's actually better than baseline in Group 1, and in Group 2, it's literally non-existent. Here you have pulsatility index. Again, their pump is very close to baseline. The roller pump pulsatility, not. And over here, percent change from mean arterial to EEP, which is, oh God, I forgot what EEP was. It's in this study right here. I don't remember what EEP was, but so we're going to skip that one. Forgive me. So I don't know that one. It's in this study right here. There's EEP. You find it?
Nope.
No,
ECC.
that's ECC.
Yeah.
Yeah, I'd have to go look it up. But it doesn't matter. Let's go on to the next things. So I'm going to blow this up a little bit. So mean arterial pressures basically stayed the same. Peripheral vascular resistance, or your SVR, basically stayed the same. And that's throughout a 360-minute pump run. Here you have hemoglobin levels, basically stayed the same. And here you have peak pressure in the arterial line, much higher with their pump. The roller pump, not too bad. Of course, I don't know what the flows were. I'm going to show you some peak pressures, which are really going to surprise you. And then Group 3, of course, there's no pulsatile, but it is a roller pump, so you have something that goes on there. And here we have renal blood flow, almost no difference between the three groups. In fact, it's better in Group 3, which is the continuous flow, which is the solid line. Here you have renal blood flow you have blood flow to the colon, basically stays the same. You have here your inflammatory mediators. Interleukin was higher in the pulsatile groups than in the non-pulsatile group, but not significant. Interleukin, another one of the interleukins here, whichever one that says, basically the same. Lactates, basically the same, actually a little bit higher in the continuous flow group, but still all of them went up, and they all came back down fairly quickly. And then plasma-free hemoglobin, much, now that was significantly lower in the non-pulsatile group. And there's a good reason for that. And then here you have escape rate. This is basically plasma leak, capillary leakage. You can see with the pulsatile of the Group 1, which is their device, it was much higher. With the pulsatility from the roller pump, a little bit less, and about the same in Group 3, which is the non-pulsatile flow at all. Okay, and I think that's the one I'm at. Yep. So in conclusion, I thought this was very interesting. With our new pump system, we were able to mimic a physiological pulse pressure pattern. Despite this precondition, as is demanded by the supporters of pulsatile flow, we did not find any advantage on regional blood flow or inflammatory reaction in the pulsator group compared to the pulsatile or non-pulsatile roller pump groups. Moreover, the pulsatile regimens led to an increased hemolysis and an elevated capillary leak. With these findings, we disprove our hypothesis of the superiority of extracorporeal circulation with a physiological pulse pressure waveform. Therefore, we conclude that pulsatile flow during mild hypothermic ECC is unnecessary. Efforts to optimize pulsatility do not seem to be justified. However, the study was conducted in normal, healthy subjects. Therefore, a possible benefit of pulsatile perfusion in patients suffering from cerebrovascular disease or renal insufficiency cannot be excluded. I thought that was that to me, when you're there to actually do something that is a business you're gonna run, and you could come to this conclusion, you give a lot of credibility to yourself.
What you didn't describe the pump that they
It's
were
a-
trying? Is that
no.
a centrifugal pump?
No, it was.
No.
It's a no. It's not. It's a good study. I think I put the reference up here. You can look that up and look at the pump, but that's not sort of where I was going with
Right.
this discussion. But here it is right here. And it's in the Cardiothoracic Surgery Journal, cardiopulmonary bypass with physiological flow and pressure curves, pulses unnecessary by Voss and colleagues. So I would look that up if that's what you want to do and learn more about their pump system. Okay, so let's see. Very good. So here's me pulsing on a centrifugal pump. And what I did was I am measuring the pressure in the arterial line before the oxygenator. So between the centrifugal pump and the oxygenator, okay? And this peak number, this goes to 350, and then we'll read dashes. That's the highest it will go. So you get dashes, you don't get a number anymore. So it's above 350, and that's what the pulse looks like on the patient's radial. Okay. Here, I'm at a lower flow state. I have a peak pressure of 343, an end diastolic pressure of 11 in the system, and there's your pulse, 46 over 39. Nothing near physiologic. And I only did this to try to give myself some numbers that I could actually see. I'm going to show you a couple of videos of what it looks like. And then show you up on the monitor. All of this going on to give you this. And you saw the oxygenator. Look at that again. See it right there? This does not seem safe to me, intuitively.
Yeah, I don't know that anyone has ever definitively closed this question because there's often, in the time that I was coming up, centrifugal pumps weren't really good at pulsing. Mm-hmm. They've gotten much better over the years. So the first study where they were comparing a roller pump was the reason I was questioning what type of pump they were using. I don't know that I've seen a real benefit in, close to normothermic perfusion for pulsatility that I could definitely point to and say this is superior. Some patients seem to respond to it, some don't. And I really don't have an argument against it as long as your volume is such that you can provide it.
So in my view, this is enough. 337 over 26 to give me a pulse pressure of 65 over 49, which is 16 millimeters of mercury, which has no physiologic benefit whatsoever. So what's my risk to benefit ratio? And just looking at that, that's enough intuitively to tell me I don't want to keep doing that. I don't want this 80 times a minute, 343, or over 400 is really what this is going to be for this. I don't want that. I don't think that's good.
I thought that
80 times a minute.
The plasma-free hemoglobin slide was informative of why you might make that argument or,
Absolutely, and that's nephrotoxic.
Yes.
So we're trying to perfuse the kidneys to do what? Okay, so, and that's another issue. We talked about that earlier, is what mean pressure do we really need? We are too hypotensive for too long for both the brain and the kidneys. The kidneys are very sensitive to hypotension and hypoxia because, as I told you, your outer medulla has a PO2 of 20. It can't afford to lose any blood flow. And if you have hypotension, you will divert around your kidneys. You will shunt away. And that is going to be very deleterious to your kidneys.
Yeah, I always tell my students that I have the saddest job in the hospital because my job satisfaction comes from urine.
That's very true.
It's not how much you pay me, it's how much the patient's peeing
That's right.
makes me happy.
Isn't that the truth? Well, you know what I always say whenever we put somebody on ECMO in the ICU and they were in serious trouble. If they start to pee, we're going to be home free. It tells you so much about what's going to happen with this patient.
It really does. It really does.
From a how they're really doing, the urine, the kidneys play such a major role, and our renal failure rates are still remarkably high given how long we've been doing this, and they have really remained high for decades. We've made some change, but over the past 20 years, renal failure rates haven't changed very much at all. You just saw that one I had up there from 2010. It is not changed in a long time. And we're just now saying, well, maybe it's DO2. Well, okay, it's DO2, but you can flow 5 liters with a hemoglobin of 7 and not achieve this magical 270. So if you don't have the volume, now I'm going to need to add blood, and you can't overflow your venous return because then the heart's not empty and they can't see. So I think, I get the whole thing that blood is a tissue transplant and we should try to avoid it to the best of our ability. But if you need it, you need it. Which is the lesser of two evils is what it really comes down to. And hypoperfusion is bad.
Yes.
Loss of viscosity because of excess hemodilution and loss of the oncotic force of your red blood cells is bad. And so what do? We're in a catch-22. Damned if you do, damned if you don't. That's what it really comes down to. So if you look at your LV, your aortic, your LV outflow tract here, and your aortic root, it's going to be between 2 and 3 centimeters, in that range. The cannula is only about 7 millimeters. The distance from here to here is not very far, measured in really millimeters, maybe a centimeter or 2, maybe. And our tubing from the centrifugal pump to the patient is 10 feet of 3/8 inch tubing that is rigid by and large. It's not truly rigid. It's not rock solid pipe, but it's pretty stiff. It can compress. It's not going to expand very much. So you don't have that surplus hemodynamic energy that you do in a blood vessel, like an aorta, a large vessel that expands and contracts and all of that. How do you expect to generate a pulse? How do you expect to do anything good by trying to flow at 8 liters and then down to 1, 8 liters and down to 1, all in just a short bursts of time to create a pulse that is, in my view, meaningless? I put pulsatile perfusion and RAP in the exact same category. They should never be done, period. Unless you want to transect the aorta and hook a pump directly to it so that the distance is short and there's no size mismatch to really get a physiologic pulse. You can do that if you want to do it. I don't think that's a good idea either. But in lieu of that, just have good mean arterial pressure, good flow, good DO2, good hematocrit, all of these things that we need to do. But people get into these pigeonholes of, we've never given blood. how do you have a cardiac surgery program and never give a blood? I don't believe that. I hear all these stories. You're being uber selective. You're not dealing with the same patient population. And I think that's another thing with all of these talks that I hear and go to and conferences where everybody espouses these incredible capabilities of never giving blood. It's just not true. This isn't true. Okay. Here I show this, the size of the aorta. That's the whole reason that's there, and the blood coming out, but the mismatch in size. And this section here is really rigid. That's pretty rigid because it's got to go in. And the ones that are soft, I've seen them have a lot of problems with those. They come out easier. But Stevie Nicks, no, I'm Taylor Swift. Again, just because you call it pulsatile flow doesn't mean it's really pulsatile flow. So that leads us to cardiopulmonary bypass and inflammation. That's the hidden enemy. So we've figured it all out now. We're finally got to inflammation. It's not pulsatile flow. It's not mean arterial pressure. It's not DO2I. It's inflammation. So once CPB is initiated, there's an extensive endothelial dysfunction cascade that's initiated, release of TNF alpha, interleukin 1. They bind to endothelial receptors, activating these cells. The process is pivotal in the integration between inflammation and triggering of the coagulation system. TNF alpha initiates shedding of both heparin and heparin sulfate and syndecan 1 from the glycocalyx. And you have measurable glycocalyx degradation products, if you measure them, when you go on bypass, which is a marker for this inflammatory cascade that takes place. So I was like, well, okay, maybe I just have to admit it. Off-pump surgery is better than on-pump surgery. I finally have come to the realization that the pump is so horrible, so bad, I need to just quit what I'm doing because I can't do this in good conscience. So then we get to this. This was published in 2022, so it's very contemporary. Here's what they did. I'm not going to read all of this for you word for word, but the 15-year survival rates for on-pump were 82.9%. And for the op-cab, it was 80.7. Your hazard risk adjusted all-cause mortality was higher in the op-cab group than in the on-pump group, and for having MI, higher in the off-pump group than the on-pump group. On-pump versus off-pump grafting. Should the debate even continue? I thought this guy wrote this very, very well. I will read this to you. But they looked at 15,000 patients on a bypass, 6,950 off, doing op-cab, VA system, 3 large multi-center randomized trials, more than 75 single-center trials. Incomplete revascularization was the #1 big problem. And there were no significant differences between stroke, MI, and renal failure requiring dialysis. In summary, this, in their case, small study to the complex and heterogeneous body of evidence in the op-cab versus cabbage outcomes arena. In 2018, it did appear that on-pump cabbage is still the gold standard. As these other folks eloquently articulate, the time for debate may be over. It is time to move on to address the issues in a more patient-centered fashion as to which patient may benefit from either approach. There are times it is appropriate. Porcelain aorta, perfect example of that. Undoubtedly, there will be high-risk patients who will benefit from a no-touch aortic technique to minimize embolic stroke risk, as will patients who seek to avoid sternotomy for pulmonary or cosmetic reasons. That would be the robotic takedown of the memory, single vessel, keyhole incision, no sternotomy. I get it. That seems like a reasonable operation to me, too. The growing popularity of robotic and minimally invasive surgeries and hybrid CABG PCI procedures attests to growing of fact that there is more than one way to surgically revascularize the ischemic myocardium, and that in the final analysis, surgical decision-making has to revolve around the best technique for the individual patient. I thought this guy made tremendous sense.
Yes, obviously patient selection is probably the key to everything that we do.
Everything.
But we have to remember the 30, 40 years, I mean decades, that this operation has been performed. And of course, we're always trying to innovate, trying to try new techniques. But we have really, I've had my aortic valve replaced, and while I was in there, they did coronary bypass, so I'm not just a perfusionist, I was a patient, and I opted for the technique that has been developed over 30, 40 years' time, good visualization, nice big open spaces to work on.
No TAV or hybrid CABG.
I went on pump. And, I was a little loopy for a while, but my wife will tell you that wasn't that big a difference. She couldn't really tell that I had the post-pump syndrome that we get blamed for all the time.
Yes.
There are new techniques, and it's great to try op-cabs. I think it was a valid attempt, and for certain patients, it's still the right choice. But when it came my time, I wanted it done the way that we're talking about inflammation now. We used to talk about patients that went feet first out of the OR versus,
Sure. I agree with you 100%. I agree with everything that you said, except I disagree with the part about OPCAB being good. And I'll tell you why I say that. I think it is in very selected cases.
Exactly.
Very selective cases. So let me just impart this to you. In 2010, 19% of the cases were done off pump. This was kind of the beginning of the 2010.
Okay.
Off pump craze. Ultimately, it made its way up to about 28%. Today, it's actually less than 11%. This is 2021. It's actually now at 8% was the last data that I got. An operation is tried and true when it continues to grow, eventually maybe plateaus just because of patient availability or need. But when it drops that much over time, there's a reason for that. You're there. The reason I disagree with you, I agree with everything else that you said, but I disagree with the part about the off pump. You're there to get the best anastomosis you could get. And I have videotaped one surgeon doing one case on pump, one case off pump, Lima to the LAD. This was a guy who believed in off pump, always believed in off pump, and he had to do the Lima to the LAD because it was an aortic valve as well. So he had no choice but to use the pump for that particular bypass graft. I videotaped his Lima to LAD down that case and on another case that he did it off pump. Both of the vessels were about the same size. Patients were about the same size. Hearts were about the same shape. Everything about the patients was really pretty similar. He looked at them side by side, and he quit doing his cases off pump. He said, that just doesn't look good. And it didn't. And I had it zoomed in, focused, so you could really see the anastomosis. And on review of it, he abandoned his off pump practice and went back to doing them on pump. You're there to get that anastomosis. It's critical. Your long-term survival is dependent upon it. You want it done in the environment that is most conducive to that. And that's a still, quiet, dry, protected field, in my view.
Yeah, I agree.
So, full circle. After all of that, I don't know what the heck is going on, but I kept the pressure at 50 the whole case. Okay, that's the end of that one. Any questions? Anybody want to call in? Any questions from you? Because I could just jump right in and just do the balloon pump and just get it. Oh, yeah. Put that comment up. Can you do that? Okay. So I did a lecture. Okay, here's the comment. And we posted this comment, by the way. I don't always get good comments. Hard to believe, but I don't always. Because, a lot of people suggest that I'm too wishy-washy. I don't have strong feelings one way or the other. Like I could just go with the flow, whatever. Did you notice that about me?
I had not noticed that about you.
No, you hadn't
No,
yet?
no.
Okay, good. So in this particular thing, the commentators, that would be me, clearly had a bias towards giving blood and disregarded a large number of studies showing that transfusions lead to worse outcomes. Although their practical knowledge and experience is important, it seems foolish to disregard new emerging, I'm assuming, was there more to that or just ... Mm-hmm. And this was Kenneth. I don't know if there's more to it.
Youth emerging data.
Data. Okay, new emerging data. And Kenneth, you're right. I think that you should not. So if I led you to believe that I think we should just give blood willy-nilly without serious contemplation, clearly not. I didn't mean to suggest that. But I don't have a bias towards giving blood. I have a bias towards allowing for too severe of an anemia. And although you are correct, the data says that outcomes are worse when you transfuse. That's true, fundamentally. The data also says your lowest hematocrit is an independent indicator for morbidity and mortality. So it's not, I am much more comfortable treating a patient's low hematocrit unless I have the volume to ultrafiltrate, but ultrafiltrate first. But in lieu of not having the volume, the excess volume to do that, I'm much more comfortable transfusing that patient than allowing that patient to be anemic with a low, not just DO2, but CaO2, low arterial oxygen content. Now, with that said, and clarify this for our audience, if you're 26 years old, you're in there for an isolated mitral valve, something goes sideways, whatever, or you're female and you had menorrhea and you're anemic for whatever reason, you're small, and your hematocrit falls to 18, 19, I'm probably not going to be all that worried about it because you're young and you are going to be able to overcome this. If you're 75-year-old grandmom who has some underlying renal dysfunction just because of age, I'm going to be much more worried, and to allow that hematocrit to ever go below 24, I'd really rather keep it at 28, much less 18. I would be horrified at that. And I'm basing this on my, not just data, because the data's there. The data, you can choose whichever data set you want, whichever papers you want to bring to the table. In fact, I would welcome you. Let's have this debate. Bring whatever papers you want, publications, evidence-based medicine, the whole 9 yards. Bring what you want, and I'll bring mine, and we'll look at them, and we'll compare the two. But my eyeballs, 44 years of doing this job, my eyeballs tell me that that patient is not going to do well if I leave her hematocrit at 18 or 19. She needs a hematocrit of 28 to 30, especially elderly, underlying renal dysfunction, somewhat depressed cardiac function. She is not going to do well postoperatively, weaning off bypass, if I don't get that hematocrit up.
That's my feeling as well. I mean, we're not giving blood in a double-blinded trial to see who does better, who does worse. The patients that I'm going to give blood to are the patients that need blood. And why do they need it? Because they're going to be more difficult. You know, they presented to the OR in a situation where, you know, you're not just giving blood. Oh, you get blood. I'm not Oprah handing out units of blood.
Sure.
You get some blood. You get some blood. No, the patients that I'm giving blood to are the ones that are not going to do well. So yes, if they get a unit of blood, they don't do well, but they wouldn't have done well without it.
Right, right. And here's the problem. Here's the problem with medicine in general, but especially in our particular domain. We don't know. We cannot give it, and the patient might just do fine. We simply don't know. But again, my experience, I don't know how many cases I've actually done, my experience tells me this patient's not going to do well. And that's part of what we do.
And I will go, I'll share an anecdote, which is, of course, meaningless. But I worked with a guy who believed in giving blood, and he wanted his patients to go upstairs with a crit of 30, 32.
I love it.
And his patients were sitting up in bed, you know, flipping the channel, asking for food. They just looked rosy red, animated. Why? Because their crit wasn't 22.
Right. Now, there's a long-term effect to that.
Certainly,
right?
certainly.
That you're right. You can't ignore the very good data about infection rates and microchimerism and immunomodulation and all of that stuff. But, you know, I mean, the lady the other day, you know, that I did had a hematocrit of less than 12 by the time I got involved in the case. And I gave her an awful lot of blood. And, and she's doing really well. She's doing really well. Okay. You know, I gave her 12 units of blood. Pack cells. I mean, what was I going? Her hemoglobin, her hematocrit was under 12. We don't know how low it really was.
Right, the machine just.
It looked like it didn't even look like Kool-Aid. It looked like vitamin water with just like a little essence of color. I was like, man, that's really low. This doesn't look good. We need to fix this.
Yeah.
But that's what happens when you bleed a lot and they're just pouring volume into you. But she's doing well. So, you know, there you go.
Yeah.
But if it weren't, I mean, obviously, I know that Kenneth wasn't referring to those kinds of patients, different scenario, but you can't just say blood's bad because it is, but what's worse?
Yeah, the absence of blood is really bad.
Yes, exactly. Yes, this is very true. I like that. Okay. So let me go to discard. Okay. So how are we doing? So I've got about 25 minutes to do the balloon pump lecture. About 35 minutes. So I stole these slides from Vicki Carlisle, who's our director of education, and she did this lecture for nurses, but we did it for perfusionists as well, and I'm going to do it from the perfusionist's perspective. Okay, so I don't want to get into a whole lot of. I don't have any relationships with ineligible companies. Here's your coronary anatomy. We're all familiar with that. We're all perfusionists, and here is the whole crux of intra-aortic balloon pumping. This is everything you really need to know. So what this is illustrating is coronary perfusion over here on the x-axis and over here, okay, the zero line that you see, and you have your going up and going down. All right. So when you're in systole, you have a little bit of coronary perfusion, okay? And then it decreases significantly at the end of systole, all right? And there's a sharp decrease at what they call isovolumetric contraction. That's where the heart is squeezing, the interventricular pressure is going up, but the aortic valve has yet to open. So you have this big drop, and then there's, during the rapid ejection phase, the valve is open, you have some coronary perfusion, then it decreases at the end of ventricular systole, and then here is diastole. This section right here is your diastolic pressure, diastolic time, dp dt. This is the period of time when you want the balloon to inflate. You want the balloon to inflate here, and you want the balloon to deflate here. And there's a way to know that you've done that. I don't want to get into the history of the balloon pump because here's Dr. Kantrowitz. He had this device. You can see how it works here. And just look at it. Vicki does a really good job on the history, but I don't want to spend too much time with it. Here's a guy with a balloon pump getting in a car, going home from the hospital. I think he's at the airport. I think maybe that's what it looks like anyway to me. And then here's this balloon pump with a closed loop automated system instead of that big surgical procedure that you saw. So what are the indications? So the indications are acute CHF exacerbation with hypotension, high-risk PCI, MI with decrease in left ventricular function leading to hypotension, MI with mechanical complications causing cardiogenic shock, low cardiac output state after CABG, failure to wean from bypass after CABG or valve, as a bridge to definitive treatment, cardiomyopathy, myocarditis, severe cardiac contusion, and LV venting during ECMO, though I don't think you get a very good LV vent. I think you're much better off with ECPella in that case. I think as an LV vent, the Impella 2.5 in the LV on ECMO does work a whole lot better, but you do get some. So there's more about the indications, contraindications, septic shock. I think that's debatable. I don't agree with that. And I think the latest trend is to use it more in septic shock, also ECMO in septic shock. It's about maintaining the circulation. The SVR is still a problem, but you will go into cardiogenic shock if you're septic and your blood pressure stays low enough long enough. Uncontrolled bleeding and coagulopathy, obviously moderate to severe aortic regurgitation, severe aortic stenosis, aortic aneurysm or aortic dissection, all of these things. All of this makes perfectly good sense.
Is AI on that list?
Yes.
It was, okay.
Yes, severe, moderate to severe aortic regurgitation. Yes. It's typically inserted in the cath lab, I think mostly now, but, you know, we put them in the OR and the ICU and so forth. You can put them in anywhere. There's what it looks like. That's the part that the table is going to be messing with. This is the insertion kit here. This is the line that goes from the table to the balloon. And this is the actual balloon here. And this is the fiber optic cable that's used to measure the arterial line pressure and so forth. And it's done with a fiber optic at the end of the balloon. But that's what it comes like. They take this syringe, they pull it back, they disconnect it, it's got a one-way valve, and that compresses the balloon. They can take it out of the package and put it in. Here's the placement. The placement usually through the femoral approach, although you can put it in axillary. You've got radio-opaque markers at the top and the bottom. So this would be the distal tip. This looks like the proximal tip. Depends on the manufacturer. And the correct placement for it is about 1 centimeter below the left subclavian artery, or what would radiographically look like the aortic knob. And we'll show you that here at a second. A little bit above the carina, generally speaking, or the second or third intercostal space. So it's really not hard to see if the balloon is placed properly or not. It doesn't have to be perfect. The impella is much more, it requires more accurate placement than does a balloon pump. Balloon pump can be a little off and still work just fine. So here you see the takeoff of the left subclavian artery there. There's your nominant, there's your right carotid, there's your left carotid. I'm sorry, this is your nominant, and it goes to your right carotid, then this is your left carotid, and this is your left subclavian. So you want it to be somewhere in this region here is where you want it to be. And here you see your dashed line here at your carina. So you want your balloon catheter tip to be somewhere in this area. This is the knob of the aorta. It could be here and you're going to be fine. It can be here and you're going to be fine. It can be here and maybe it's a little low, but you're probably still going to be fine.
And you don't need, I mean, you like to have radiographic confirmation of the placement, but if you just lay the catheter over top of the patient's anatomy, you're going to be pretty darn close.
I agree with you 100%.
So there's no, you can check it later once you've got
agreed,
the
100,
technology.
agreed 100%. So here it is placed in the femoral. You see it on this side and coming up like this and positioned, and then here you see it going in through the axillary, and it is in inverse position, going essentially antigrade versus retrograde, but nevertheless, the function is going to be exactly the same. It's going to work the exact same way. Oops. And here's what I talked about earlier. There are 8 phases to the cardiac cycle. We're only going to focus on a few, 4, 5, or 5, I guess 5 of them, or 6 of them. There's isovolumetric contraction. Again, we talked about that. That is when the intraventricular pressure is rising. The heart is beginning to squeeze, but it has not exceeded the aortic pressure, so the valve is still closed. Isovolumetric contraction. Then you have the rapid ejection phase, which you see right here with that sharp rise. And there's another phase after that called the reduced ejection phase. So you have rapid ejection, reduced ejection, and then comes isovolumetric contraction, or relaxation, relaxation. And that's where the intraventricular pressure is falling, the aortic pressure is falling, and you see this little blip right here. This is the dicrotic notch. That dicrotic notch is where you want, because that signifies the aortic valve closure. That is where you want the balloon pump to inflate. That will displace the volume in all directions, but back towards the coronary arteries. The valve is already closed, so you don't prematurely close the valve, and that increase in coronary perfusion, or that intra-aortic pressure, increases your coronary perfusion pressure and increases your coronary blood flow. That is how that works. Very simple. So this period of time from here to here is when you want the balloon pump to inflate. This is the area just at the point of isovolumetric contraction, when the cycle starts all over again, is when you want the balloon to deflate. You don't want to deflate it here, because you won't have any effectiveness of the balloon. We'll talk about that. That's early deflation. You don't want to deflate it here, because now you're obstructing the aortic valve from being able to open. But the key is, if you deflate the balloon at the point of contraction of the heart, isovolumetric contraction, when you actively and rapidly deflate it, there's a void that was once filled with a gas-filled balloon, and blood from on top of the aortic valve, as well as other places, is going to rush to the area that was once occupied by that balloon to equilibrate, because we have to be in equilibrium, that we must be. So that has to happen. And when it does, it's like pulling a door, having someone pull a door open that you're pushing open, and it makes left ventricular ejection much easier. So you're increasing coronary perfusion pressure, increasing coronary perfusion blood flow, you're decreasing left ventricular work effort, because you're decreasing the afterload by which the ventricle has to eject. So you reduce oxygen demand, increasing supply, decreasing demand. That's everything you need to know about the intra-aortic balloon pump. But there has to be more, because if I don't do more, we will end too early, and then the board will be mad at me. Okay, so here it is. You see it working here. And basically, when this balloon inflates, blood is displaced in this area that you see right here in all directions, even down this way. But the increase in this pressure is what we're looking for. And as the ventricle is contracting, before that valve opens, you deflate it. Now the blood wants to rush from all directions, but from here in order to equilibrate, making the pressure in the aorta right here lower than it was here. Higher pressure, lower pressure. That decreases afterload. And here you see the what I talked about earlier, DT, diastolic pressure, diastolic time. Your T wave or your R wave is the beginning of your cardiac cycle, your ventricular cardiac cycle. And most balloon pumps are by default R wave deflation triggered. So it looks for that to deflate, because there's going to be an electrical mechanical delay between your electrical signal EKG and the actual mechanical movement of the heart, short as it may be, probably in the neighborhood of 50 milliseconds, something like that. And then you're going to have the balloon is going to deflate there, and the T wave is your beginning of ventricular repolarization, and that's where you're going to inflate the balloon. So this is your inflation balloon. This is your deflation just over here, probably a little further out this way. I'm not a very good artist. I'm not good at drawing. But you get the idea. And all of this is increased diastolic pressure and diastolic pressure over diastolic time. The time, because the heart rate may be the same, but you have a higher pressure over a longer period of time. And that's illustrated here. The balloon going up, staying inflated, actively deflating, and then the ventricle, and then here again you see the balloon inflating. So this is deflation, this is inflation. And there again, that illustrates the exact same thing that we just got through talking about. Oops. Okay. Correct IABP waveform. So, a couple of things I want to teach my perfusion colleagues. You can only time a balloon two ways. Way one is hit the automatic button, and it will auto-time the balloon. Doesn't mean it's timing it well, but it is doing it automatically.
And compared to 30 years ago, that's remarkably better.
Pretty good.
Yeah.
Pretty good. Because 30 years ago, if the heart rate was changing and you didn't adjust the balloon, you could be doing a tremendous amount of harm.
You could.
You really had to pay attention to it. There was a time when perfusionists would sit at the bedside monitoring the intra-aortic balloon pump. You remember those days?
Oh, absolutely. Yeah.
Absolutely. Yeah. Incredible how things have changed. So that's way one. In lieu of that, way two is it must be on 1 to 2 or 1 to 3. You cannot time a balloon on 1 to 1. So 1 to 2 is preferred, in my view, for me. It's personal preference. But 1 to 3 will work. 1 to 2 is how you can time the balloon or confirm the appropriate timing. And what you're looking for is, because if you're on 1 to 1, you may not see your dicrotic notch, which you got to look for. You look at that and you want to be inflating the balloon at the dicrotic notch. This balloon inflates and it has remained inflated. It is actually still inflated this entire time. All that line that I just drew, it actively deflates right here. So the reason for the pressure drop is the same reason of any pressure drop, right? It's dissipating out. That's what happens. But the active deflation occurs, and then you have another patient ejection. What you're looking at, the reason you do this, because this beat is preceded by no balloon pump support, it's referred to as the unassisted systolic pressure. This one is preceded by a balloon pump deflation. It is the assisted systolic pressure. Your assisted systolic pressure should be lower than your unassisted systolic pressure if your deflation timing is correct, because you are decreasing the afterload, therefore decreasing the pressure. You are decreasing you're basically making it easier, lower pressure that the ventricle has to generate in order to get the aortic valve to open. That's why it has to be that. Furthermore, you want your assisted aortic end diastolic pressure, this is being measured at the tip of the balloon, lower than your unassisted aortic end diastolic pressure. So now I've told you everything you need to know about balloon pumps. How are we doing on time?
Yeah, I got about
15
15 minutes.
minutes? Okay.
Or I have the other people on.
You do?
It looks, they're getting ready.
Okay. Variables that affect augmentation: balloon position, balloon volume. So if you have a 34 balloon in a patient that's 6'5", weighs 280 pounds, then a 34 balloon is probably not going to be right for them. If you have somebody like me or you, a 40 cc balloon would be appropriate. Somebody like that's going to need a 50 cc balloon. So you have to have the right size balloon for the patient.
Given their vascular limits.
Of course.
Because obviously if they've got a very tortured aorta,
Yes.
you may not be able to get the optimal balloon in there.
Yes. You know what? My call this weekend, I was tortured. so I understand about that, but you are 100% correct. You do have to consider the anatomy of the patient. That is correct. Timing errors can disrupt your augmentation. Stroke volume that's less than 25 mLs, the augmentation will be minimal, and severe vasodilatation or contraction, or constriction rather. So basically changes in diameter will change the occlusiveness of the balloon, which is something else you have to remember. If you use FlowTrack, which derives cardiac output from pulse contour analysis, and you're using an intra-aortic balloon pump, it will not work. So your FlowTrack will be completely off. The numbers are completely unreliable. FlowTrack is designed for a pulse contour analysis of a balloon pump.
You're referring to the hemisphere
Yes.
acumen
Yes.
transducer.
Yes.
Uh,
Lidco.
yes, there are a couple of different names.
FlowTrack, whatever, yeah. All the different companies. So here is a correct waveform. Now, if anybody gets any of these questions correct, you win a prize. That includes you. Okay? This is a correct IABP waveform. We see our unassisted beat, systolic, is higher than our assisted. We can see here's the dicrotic notch. We have a nice V right here. So we're right at that dicrotic notch for our inflation. remaining inflated, actively starts deflating right here. Our aortic unassisted is higher or lower, as the case may be. Our assisted is lower than our unassisted. This is perfect. How about this? You cannot assess it. Why? Because it's 1-to-1. Cannot assess that timing. It looks good.
It looks good.
But that doesn't mean anything. You cannot truly assess it. Okay? What's wrong with this one? Anybody want to guess? You win a special prize.
It's hard to visualize the dichrotic notch on the unassisted beat, and it looks like it may be deflating a little early, but you've got a good pre-systolic dip. So that doesn't look too bad. I would say maybe a little early inflation, but
I think a lot early inflation. Here's your dichrotic notch here. So
okay.
we're right around here. So we're walked way up. Here's your dichrotic notch right here.
All right, I was looking at that as if it was
Just a
an
rebound.
incompetent, yeah.
Yes, it could be. They could have a little bit of AI, which you will see that. That's not uncommon. You're 100%
Or
correct.
hypovolemia sometimes even will shift that.
Possibly. Very good. Okay, what's wrong with this one? Thomas DeSalvio, late deflation. Early inflation, late deflation. So, Thomas, you are right. Early inflation. You win a prize. So, and your prize, yes, you can guess. And, Thomas, your prize is more call. I just get such a kick out of that.
I'm glad I didn't win.
No, you'll get more. You'll get something. Okay, what's going on here? Anybody can guess. Thomas, you'll actually win something good. I'm taking you to lunch. Any thoughts? Here's your dichrotic notch right here. Remember the previous tracing. I'm going to go to it just so you can see it. You see the inflation, that nice, pretty V. So let's go back to this. Any ideas? Your unassisted systolic is higher than your assisted a little bit. Your end diastolic is lower, so that's not a problem. So what, if anything, it's subtle. Thomas, you got it right, late inflation. He wins 2 prizes now. So your inflation is a little late. Of all the timing errors, which is the timing error that you want the most? A little late inflation never really hurt anyone. You're not getting 100% of the benefit, but it's pretty benign. You can get, of all the things you can have. Okay, what about this one? Any ideas? Let's see. Looking online. What do you think? So let's look. Here is your assisted systolic. Here is an unassisted systolic. Here is an assisted systolic. So not much of a change there.
I think you read those in reverse. This one is unassisted.
Yes, unassisted and assisted, yes. So your unassisted systolic is not much different. So that would maybe be, what would it be?
That you deflated early.
Exactly, because you've allowed for all of the blood to now equilibrate, and you have done nothing to decrease afterload.
You still see a pretty good pre-systolic dip compared to the
You're saying here?
Yes.
You do, and you will. So here's the balloon. The balloon deflates. The blood rushes from the valve and everywhere else, fills the void. It now all equilibrates, and then you have a systolic. That's why it's so important to inflate during that isovolumetric contraction phase, because if you do it too early, all of the blood is equilibrated and you've not changed the afterload at all. Now, you've helped with increasing coronary perfusion and coronary perfusion pressure, but you've done nothing to reduce afterload. Juan wins a prize. More call. Okay, what do you think about this one? This one is almost too obvious. You have your unassisted systolic, your assisted systolic, which is very, very, very different, much lower, but your unassisted aortic end diastolic pressure is lower than your assisted end diastolic pressure. So, anyone want to guess?
Not sure on this one.
Well, so what are the two reasons why your assisted
Deflated a little late, maybe.
a lot late? Because you don't see any
Pre-systolic.
decrease in your aortic end diastolic pressure is higher than your unassisted. So that's significant late deflation. And the reason why this pressure is lower isn't because we're benefiting the patient, it's because we're obstructing outflow. That's right. So we're compromising LV ejection. Okay? This, I think, is going to be maybe the last one. I'm not sure. Let me see. Are those folks ready?
We have Marty on. Danny's not on.
Okay. All right. Anybody want to pick this one? If anybody gets this one, they win a super special prize. So here's your dichrotic notch. You can clearly see the dichrotic notch.
Yeah.
Uh-huh. Remember, we were looking for that nice, pretty V.
Slightly delayed.
So little
Inflation.
late inflation. Okay, good. That's one.
Not horrible, but
A little. And here's your unassisted systolic and your assisted systolic. Essentially the same. Aortic end diastolic, unassisted. Assisted, just a teeny little bit lower.
Improvement there,
So
but-
what do you think? It's late inflation. That part's correct. And early deflation.
okay.
So that's why your assisted is not significantly different. The balloon is deflated too early. Even though you're not seeing a big drop here,
Yeah.
and that tricked you, and I get it. But that is what it is. This one really illustrates it a lot better. You can see it's come down and it's leveling off and then it's coming up. And this pressure should be lower than this pressure. It's definitely not late deflation. It's early inflation. That one is almost, I think this one is early inflation and late deflation.
Yeah,
That's my view.
That's the double.
Okay. And let's see. We don't need to do all that. Okay. Hey, you know what? Was that fun?
It was
That wasn't a bad talk.
better
Wasn't
than a
good.
stick in the eye.
No, Vicky's much better at it than me. It's better than a stick in the eye. Okay. Well, I mean, I'm glad to keep expectations low, Juan. That's what I always say. Under promise, over deliver. That's right. Okay. You want to bring those folks up? I need their names.
It's Danny and Marty.
Okay. Hi, Danny.
Hello.
Hey, Marty. How are you?
Hi.
Welcome.
How are you?
So,
Fine.
I'm doing fantastic. So for our audience, if I could please, y'all are coming to us from Spain today, and you're from Barcelona or Madrid?
Barcelona, actually.
Barcelona. Wow, beautiful city, incredible. Oh man, I'll tell you what, I wish I was there. We should be there doing the program on site.
Not advisable because today it's raining, so it's a bad day to be in Barcelona.
Oh no, it's always a beautiful day in Barcelona. So Danny, let me just ask you one favor. If you could move about 4 inches to your left, because on our screen you're cut off. Perfect. That's perfect. Oh my God, that's perfect. You did perfect. Thank you so much. So, you came to me through our our technical director, Maciek Skradalovic. I know you had an opportunity to visit with him a little bit on the LinkedIn and stuff. And I know that you guys have I talked to somebody else within your organization. So you're going to have to forgive me because I'm going to need you guys to do maybe a little bit of help me a little bit with your introductions. Sure. But I understand that this lecture was given at one of the AMSEC conferences, and that your concept or your product line involves AI simulations for medical training, and I guess use of, if I get this right, forgive me if I don't, just tell me, but use of some gamification for your simulation process. And I think it's a really fascinating topic. The name of there's your company, Vermedics, AI for healthcare training. So I'm going to turn this over to you, and maybe Danny and Marty, you can give some introductions so that we know who your company is, who you are, and our audience can get a feel and where they can learn more about this. But we're very interested, and I'm going to sit back now, stop talking, which is very rare for me to do, and let you guys go forward with this. But thank you so much for sharing this information with our audience. We appreciate you very much.
Thanks very much to you. It's a pleasure to be here, and we are going to split the conversation into stages. First, I will introduce the company, and I will talk about gamification, and then Marty, who is our chief of AI, will talk specifically about artificial intelligence. If this is fine for you.
Yes.
So I'm going to share my screen. I have prepared a presentation. Great. So you will have to pass my slides. So I'm Danny Tost. I'm the CEO of Vermedics, and I'm together with Marty De Castro, who is the chief of AI, as I just said. So please. So who we are? Let's first start explaining who we are. We are a company based on the belief that a better healthcare education leads to a better healthcare system. So we are focused on education with the mission and the goal of having, in general, better healthcare. And this means not only better healthcare for the patients, but also better mental and well-being behavior for the clinicians. So we are based on 4 cutting-edge technologies: simulation, gamification, and we are going to explain this term of gamification, virtual reality, and artificial intelligence. So basically what we do is video games for training that you can use on the website directly with or without glasses, stereoscopic glasses. And we put artificial intelligence in top of all of that, and we will see how during this conversation. So just a sneak peek, this is CPB. This is a product which is already available, and it's about training the cardiopulmonary bypass. So this is a real machine, and you are going to see how is our virtual machine. So in our game, what you can do is to enter in a virtual scenario. Here we can see you enter in the website, and you just play. You have different kinds of patients, different kinds of surgery, and your role in the game is, as a part of a team with surgeon and anesthesiologists and other nurses, your role in the team is to be using a cardiopulmonary bypass machine. You have to talk to the surgeons, to talk to the anesthesiologists. You have alerts because the variables should be within the range of normality, and you have to operate everything. When the training program is made of a lot of tasks, different scenarios, different kind of patients. You have also quizzes to test your theoretical knowledge, and all this is gamified, meaning that you have points and scoring, and at the end you have a debriefing with all what you have been doing correctly and incorrectly. And of course, you have the scoring, all the points and everything. So this is an example of how we have been using this software in the Hospital Clínic de Barcelona, which is the main hospital in Barcelona. So this is for VCPB. Actually, this video, you will see that the machine is a little bit old. We have the new machine now, inspired in a very recent model that has just been launched to the market 1 year ago. This is VCPB. We are currently working on another game, which is Vir ECMO. This is a sneak peek because this video is not yet on the market, but you can see it's an ICU, and you have 2 or 3 different patients. Some of them should go on ECMO, some others shouldn't, and you have to deal with the different maintenance problems that you can have. You have to deal with on ECMO and to winning from ECMO. Looking at the variables of the patients and understanding all what has happened. So we can switch and go to the third line of products. It's AI. I'm not going to talk about it because Marty will go through it. And just for you to know that we also have a line which we call Atelier, in which we can, you can, if you have any concern, any need of a special game specific for your company, we can also do a game specifically for you. So this was a brief introduction of who we are. And let's start the presentation about what's gamification and what gamification can bring to all this this software. So today we're going to talk about the role of gamification and the role of AI in perfusion training. So starting with gamification. Gamification, it's a big word. Let's start with simulation. So I think that for everybody here in the audience, it is clear that simulation is very important in medical education in general. I'm not going to go through all the bibliography. I know it's quite complicated, but just for you to know that there is a lot of literature about the importance of simulation in medical education in general. So you have some papers at the beginning, 3 papers about in general simulation in medicine, and below you have some papers about the role of simulation for perfusion education. All these papers in the general scope of medicine and nursing and in the specific scope of perfusion agree in one very clear conclusion. Simulation is essential for training professionals because when you practice something, when you make errors, it is when you really learn. Now, most of the scientific core of information about simulation, especially in perfusion, is focused at hi-fi simulation, using devices like Califia or Ferus that substitute the behavior of the patient in an intervention. These machines are great, and really they have a very strong impact in the formation of perfusions. However, our approach is a little bit different. We think that in addition to hi-fi simulation, it is also important to have purely virtual simulation. And this is what we do. These games that we do are purely virtual, so you don't have really a machine in front of you. All you have is a virtual environment. So with our simulation, you cannot train psychomotor skills, but you can train your knowledge, obviously, the procedure to know when to do the things, why, also soft skills like decision making, like troubleshooting, like communication with the team, which is essential, because most of the errors that are done in a surgical room in general and in perfusion in particular are related to communication. and you can train in an unlimited number of training scenario. And what is more important, you can customize the games to the specific culture of your hospital. We all know that each hospital has a particular way of orienting cardiovascular surgery. It depends sometimes on the surgeon, sometimes on the hospital in general. So it is important when you train to be able to train just as it will be in your particular hospital, or in this hospital and that other. So for this, having a software simulation is very practical, because you can customize, for instance, change some parameters, the kind of cardiac index that you are going to use, or the way that you really want to enter and pump, or the dialogues that you want to be said in specific context within the intervention. The main advantage of simulation as ours is that they are very cost effective. Why? Because many people can play in parallel. The only thing that you need to play is a connection to internet. Of course, if you want to have the virtual reality headset, then you also need an internet connection, but then you need to buy the headset. But then you can just connect with our software, and that's it. So it is ubiquitous. You can play from anywhere. You can play from a beach. You can play from Barcelona or from New York. And the advantage is that it is relatively low cost in comparison to hi-fi simulator. So it's a very good complement to these hi-fi simulators. As a matter of fact, our experience with the Hospital Clinic of Barcelona is that they say that when students have been training with a virtual simulator, then they have better efficacy when using a hi-fi simulator. So it's time saving and very important. It is reproducible, and with this we can also extract a lot of information. So the learning analytics provide us a lot of insight of what are the problems in training, where do students fail the more, what is easier for them. And in addition to all this, virtual simulation is fun. And we are going to go fun. So come on, a game. We want to train serious perfusionists. We want to train serious clinicians. This is serious. How can we dare to talk about games when we are talking about clinical education? I'm going to say it just right now. So the importance of playing. I'm not going through a philosophical discussion, but you have to know that the concept of gaming and the importance of play have been studied from different approaches, from philosophy, from pedagogy, from psychology. And it seems that playing is an activity that is core to the human being. So we play not only when we are children to create our personality, we also play in our real life. So playing is an essential component of our lives, even though we often don't dare to say it. What are the characteristics of the game that are so important? So when you play in a specific place or environment. It can be a simple board, or it can be a fictional place in which you decide that you are playing. In our game, the magic circle is the virtual environment that we create. So you enter in a surgical room that we have set up for you. There are rules that are freely accepted, and this is essential because when you play, you know that you are playing. So if you lose, it's not that important, because you know where the rules were and you accept them freely. What is very important is that you have very clear partial and final goals. So in our game, this is related to the levels of difficulties and of the specific goals of each task. So you first learn to go on pump. Then you learn to compute, to maintain in a normal case. Then you learn what happens if the blood reservoir suddenly drops. Then you learn what happens if the venous saturation is low. And so you learn progressively with very partial and final goals. The final goal, obviously, is to be able to carry on correctly a CPB intervention. You have interaction, so you have to touch the pump, you have to raise it, you have to clamp the lines, you have to inject some or to put some drugs. There is feedback result, as we have seen in the videos previously. You have a lot of feedback. You are doing this well. You are doing this badly. You have points. You have all these kinds of feedback. And there is a story within our games. The characters have stories that happen to them and that you can follow just as it was real life. And there is competition because at the end, what you want is to improve your score. So if you make a game with 100 points, is better than if you win the game, but with only 90 points. And there is challenge with others because we also have a board in which we put every week the best students and the worst students. And overall, games bring fun and even, we have to say, addiction. So why introducing games in perfusion? Because it's all about emotions. Emotions play a very powerful role in supporting or undermining learning. Learning is conditioned by the emotion. Positive learning emotions bring interest, curiosity, creativity, engagement, joy, and they impact on a better focus, better attention, and better acceptance of criticism, and less fear of errors. So if you learn from the emotion, you have a better impact. So you learn more and you learn for a longer period. Whereas in traditional education, you have sometimes negative learning emotions, which are the stress, the fear, the worry, the anxiety, that impacts on lack of focus, disengagement, and at the end, low learning outcomes. At the end, the benefit of gamification is no fear, no guilt, errors are welcome. All what can happen in one of our games is game over. And game over is not such a bad situation. Okay, so how we have introduced this gamification in our simulation. So we have to say that what we have is simulation. But on the top of this simulation, what you have is some elements of games. So the user interacts with the virtual environment. The virtual environment, in the virtual environment, there is a task, a scenario, a case that is going to happen. And we model the procedure, how it should be, how a specific procedure should be done very specifically. And we also model the physiological model of the system patient machine. And on top of that, we have levels of difficulty, the magic circle, the narrative, the feedback, the lives, the points. And we generate all the results. And the results also are gamified because you can get diplomas, you can get challenges, and there are rankings everywhere. Okay, so that's for me. And now Marty is going to talk to you a little bit about artificial intelligence.
Yeah, thank you, Danny, for that. So I'm going to do, before going in depth on how we integrate these new tools, this is something that it's on trend, in the trend about that it's artificial intelligence. I want to do first a step back to put a little bit of context of what's artificial intelligence, or at least how we understand that, and then also the different types that we have, because you will see that it depends on the point of the game, on the part of the game that we put the focus on, we can use these different strategies. So first of all, what is artificial intelligence? We understand artificial intelligence as a computer system that are able to perform intelligent behaviors. What does it mean? That having a specific context, they are able to adapt, they are able to make a decision, and actually to act accordingly the context that in the environment that they are at. So this is the first thing, and this is like the biggest field that we have, or the biggest concept that we have of artificial intelligence. And from there, we have more specific terms. After artificial intelligence, the next general term, let's say, that's the machine learning. That's something that get popular, or it's in growth. And the point with machine learning is that are systems that are able to adapt to a context, but not only to adapt and make a decision, they are also able to learn. So just having some machine and some algorithmic processes, we are able to make this to learn something from that. And then there is like a further step, that's the deep learning. That is when we start using the more complex mathematical model. I don't want to go very in depth on that. Just to mention that this is a very complex systems and algorithms that are based on the different neural networks. So apart from that, we have 4 different types of artificial intelligence that are supervised, unsupervised, semi-supervised, and reinforcement learning. In our case, right now we are using almost all these types of artificial intelligence for different purposes in our development, in our game. So just a sneak peek of these different types is like supervised is when you have an amount of data, and you know what kind of data belongs to what. For example, in this case, or an easy case to understand, is that we have like a lot of pictures that are dogs and cats, and we actually know which pictures are a dog and which picture are a cat. This will be like supervised. So what we are going to do in this case would be, okay, we are going to learn what kind of pictures are dogs and what kind of pictures are cats. Then from the next one is the unsupervised, that is like having a huge amount of data, but we don't know the level of the data. So the main idea here is just with a lot of bunch of data, what we are trying to do is to understand if there is any pattern or there is anything that could be in relationship one to another. In this case, for example, as I'm presenting here, is like we have different pictures that once belongs to apples and once belongs to bananas, but we actually don't know what are apples, what are bananas, but because of the shape, because of the color, because of these different attributes, we are able to differentiate them one from the other. From there, we have another type of artificial intelligence that is semi-supervised, that basically is a mix between supervised and unsupervised. And it's like, okay, we have a few instances that we know which one belongs to an animal and which one are plants, but we also have a bunch of instances, a bunch of information that we don't know what they belong to, but we know that they are animals and they are plants. So based a little bit on the experience or the different instances that we have, we are trying to also classify this data that it's not classified already. And finally, the last one, which may be the weirdest one, that it's reinforcement learning. That this basically is that you have an environment. It could be virtual or it could be a real environment. And actually, in this environment, you can perform several actions. The main idea here is that you are training something that's called an intelligent agent, that having a specific environment with a specific actions, by playing the game one and another time, you are getting which is the best action that you have to perform given a specific situation. Let's say, for example, in this case, that there's like a maze. So imagine that you can just go forward, right, and left. So just by repeating this procedure one another, the agent will be able to find the solution of the maze. So with this general picture of AI, then the huge question is, okay, that's amazing. There are a lot of possibilities, but how you are integrating all these in your game? Basically, we are using all of them. Here is what Danny presented before. That is what we have in our game with the different results and all this stuff. And then I also point out at the different points that we are applying these different AI methods. So I will just go one by one, explain a little bit how we are applying that and how we are leveraging the potential of AI in each case. So first of all, in the results, as Danny explained it, we are obtaining a lot of results from how the user is performing the game, where is the place, or where is the situation that the user, or in this case the student, got stuck. So by using different analytical methods, mainly based on supervised learning, we are able to get further insights about further insights about how the user is performing in the game, when he's getting stuck, and why he's getting stuck. So we could just give a better feedback and a customizable feedback to the specific user that is playing the game. Actually, this for training is a really good thing, because you can have and you can understand why you are not passing the different levels, or why you are not getting properly the concepts that you are working with. So in this case, using the AI helps us on having a better way of debriefing the performance of the user. Then we also applied, as Danny explained before, it's important to adjust the different levels of difficulty of the game, because at the end we need a trade-off between being challenging and try to user, or the student in this case, not to get bored. So having like an automatic way that we can detect how the user is performing during the game, it helps us on automatically adjust the different levels of difficulty, and to make the experience better for all the students, and of course that you can adjust more or less the level that you are playing at. Then after that, as Danny mentioned before, what we have right now is a physiological model. I don't want to go in depth on that, but basically the main idea here is that this model is based on several equations that and what we can reproduce the behavior of a real patient. So the main idea here is that using equations, you can reproduce, or you can simulate most of the responses of the patient, but sometimes there are like a specific troubleshootings or specific situations that are really, really difficult to simulate, or that you cannot get this precision, or you cannot get this customization for specific patients. So the idea here is that we are working on data-driven models that basically are models that are going to be constructed based on real data, real operational data, that will complement this physiological model that we already have, to even have even more realistic responses on the patients on each operations, and on the other side, not only more realistic, also that we can reproduce more weird situations, let's say, that situations that are not very common, or that it's not occurring very often. So with that, what we can do is that when you have a situation that it's something that it's not that you have not practiced that much, you can just use the game to train in these kind of situations that could be tough to operate. Then we also are using, we are also integrating the AI as an internal tool. In this case, the AI that we are using is using for our virtual environments. Actually, there are like a lot of work in creation the different assets of the game, just by the different 3D models that we have, the different machines, the patient models, and all this stuff. And then also there are like a lot of materials and textures that we need to obtain from that. Something that I miss here is that we also have communication inside the game, and actually all the voices from the different patients and the way the game communicates to the user in this case is also generated using AI. Then something that we are also working on, that it's a really interesting part, is that we are working in a virtual teacher. This virtual teacher consists on two different aspects. One aspect is regarding the full game. So the idea is that with all this game, what we are trying to do is to simulate realistic situations that you have while you are in a surgery. So what we can do here, as I explained before, it was one of these types that I mentioned before, using reinforcement learning. What we can do is train an intelligent agent that is able to perform the optimistic action given a specific situation. So by that, what we can do is to create a recommendation system that could give to the user, the student, or in this case, or in a real life case, can give a perfusionist, which is the action that could fit the best for the situation and the environment that we are working at. So this is something that we are working on, and also this is integrated together with a chatbot. Basically, you can have some doubts, and actually more when you are doing training the processes, so you can have some doubts, or maybe you need to calculate the BSA or some kind of calculations that it's important to have some kind of calculator ready. So using this virtual teacher, the main idea is that since we already have this chatbot, we can integrate all this with the virtual teacher. So you can have a real life situation that this virtual teacher is giving you some recommendation about the actions to perform. And at the same time, if you have any doubt, he's able or she's able to answer you the doubt that you have. So this is like the integration of the whole system here. Apart from that, this is integrated in the video game, but at the same time, the user can use the Perfusion chatbot as another product. Actually, this was the last product that we launched in the company. That is that you have a specific chatbot. Actually, it's the first Perfusion chatbot that you can ask any question as you want, and she is going to answer as accurate as possible given the information that we have. So this is something that you actually can find in our web if you just get a subscribe in the game. And then last but not least, the last thing that we are working on is just the AI have a lot of capabilities. Actually, there are a lot of powerful tools that now are raising to the market. And one of the things that we are also plan to work on is to basically getting information from real life operations. We want to create a specific scenarios or automatic scenarios just from having information about it. What does it mean? For example, if you are able to get some pictures of the operation as well as some data about how the variables varies along the process, the main idea is that we can integrate an AI that is able to reproduce or to generate this situation again for, I don't know, for training processes, for evaluating processes, for anything that you need. Finally, just to wrap up, all this information that I gave to you is how AI is helping in our simulation and how AI basically is helping us on shaping this perfusion field. First of all, when something very important is that we are able to create a more complex tasks, or in this case, scenarios. As I explained before, having further information about how the real life operation is taking place helps us on getting a more customized experiences for these kind of operations, and at the same time more realistic. So it's even closer to the reality. So when you are in real life operation, you can just get some insights from what you have been training for. Then another thing is that since we are able to get further information and further parameters from the patient during the surgery, we also can have more accurate responses of the patient, and also more specific according to the situation that we are trying to simulate. Then, as I explained, since we are getting a lot of information from the results, we can also enhance the user experience, giving specific reports, specific feedback from the things that he's doing. And at the end, since we have this personalized evaluation of every user, every student or every people that's working in our game. It's like a more specific way to also understand what you are doing wrong, or what are the concepts that you are maybe not getting, or what's the things that I need to practice the most. So at the end, what we are having, or what we are giving to our users, our students, or the people who is using the software, is just personal improved skills. So yeah, this is us. This is BirmedX. Thank you, us, for letting me be here. And yeah, if you have any doubt, we are here to listen to you.
Okay, very good, very interesting. Where did he go? Oh, okay, he'll come. Okay, so is Danny, is he a software engineer? There, where'd he go? Oh, there he is. Hey, Marty. Marty, are you a software engineer?
Actually, I finished my PhD in artificial intelligence a year ago. I'm kind of a software engineer.
Very good, very good. It's very interesting. So with the VR headset, so you can do this from a computer screen, is what I understood, and you can also use the VR headsets. Now, on the VR headsets, how do you have an app that does that, or is it just link online, or how does that work?
Dan, you want to answer that?
Sure. So you have to download the APK. So you have to download the game, and then you play connected to internet, because your results are stored into the same database. So it's the same if you play with the glasses as if you play directly from a computer. The only difference is that you have downloaded the APK, so the application, in your glasses.
Very good, very good. Yeah, that sounds. I'm curious. What I saw from your brief, sort of illustration with that was a pretty cool looking environment. So I'm curious, and Danny or Marty, either of you can answer this question. How did this all come to pass? Like, what started this whole project?
So, shall I answer, Marty?
Yeah, you can start, and if there's anything,
So it all started in the computer science department of the Technical University of Catalonia, where I've been working as a professor for many years. We got a lot of projects of creating games. So our research is on developing software for games, but specifically in the medical field. So we have been working during many years in gaming for applications in neuroscience and in professional training. And some years ago, we were in a surgical intervention, because we work in collaboration with the medicine school of the University of Barcelona. And we were in a surgical intervention where we were looking at how the mitral valve works. And in this intervention, the surgeon was a very cool guy, very nice guy, and we were working together in modeling the mitral valve. And at the moment, he said, on pump. At that moment, I have to say that we didn't know what a pump was. And the guy said, on pump, and raise the pump. And the perfusionist raised it, but not enough. So this guy, who was really charming, started to shout and to yell at her, when I say you should go and pump, it means go and pump. So it was really crazy. So at that moment, we decided we have to make a simulation game to train perfusionists.
So you've been in this space doing this for quite some time. This isn't new. Just the perfusion aspect of it is new. is the only part of this new. So are you collaborating at all with any of the perfusionists in Barcelona where you are? Is there somebody, like, do you have, I don't know if you have a school in Barcelona, a perfusion school there or not, I don't know. But if you do, are they using it? And is there anyone there that, oh, yes, can you move, Danny, I'm sorry, to your left a little bit, another
Okay.
six inches to your left, I'm sorry.
Again.
So sorry. Yes, to the left. No, the other way. You have to go left. Nope, the other way, opposite direction. There you go.
That's perfect.
There you go. Perfect. Okay. Yes, now you're perfect. As always, you're always perfect. So, so who are you working with there, and is there any hope or opportunity to learn from them?
I also was curious, are the manufacturers of the equipment involved with you?
Mm-hmm.
Are they helping you, in all your efforts?
Yeah, develop the perfusion part of the software.
So obviously we have perfusionists on board. These are the perfusionists of the main hospital in Barcelona, and they are also the lead of the Master in Perfusion, which is the Spanish Master of Perfusion. In Spain, to be a perfusionist, you need to be a nurse and then to have a master of 2 years. And this also certifies you to be perfusionist at the European level if you pass an extra examination. Mm-hmm. So yes, these persons are on board, and we also ask for advice to many other perfusionists. So each time we make a new feature, we ask to all our collaborators from the perfusion field that assesses on the contents and also on the pedagogy, on how to explain it. So not only practitioners of perfusion, but also teachers of perfusion, because mm-hmm. both aspects are important. The techniques by itself, but also the pedagogy of the technique.
Mm-hmm. Did you by any chance hire that perfusionist is being yelled at, so that when you tell the game to go on bypass, you actually go on? I was just curious.
So we have hired them, and we have hired some of them. Some belong to the company, and we have specific contract for help mm-hmm. At different moments in time.
Do you have any ability to, for lack of a better word, because I'm familiar with Califia. You mentioned that in the very beginning of this conversation, right? To have the simulator like that, and then there's the ECMO simulator, which is the what's that thing called again? I forgot what it's called. Magic. What's that thing called?
We know very well the
Eigenflow. Yeah, Eigenflow. Yeah. And but do you have any ability to sample this, experience this, number one, and number two, what's the cost? And where are you in terms of the perfusion aspect of it? Are you like in the beginning, the nascent stages of this, or are you midway through, or have you actually completed the project? Is this operational? How can it be, how can we access this? And then, of course, not just access it as a sample, but how do you purchase this? What is the cost? Because if it's cost beneficial versus Califia, which I know what that cost. I know Richard Talman fairly well, and of course I know the Eigenflow folks, but I'm curious what that is.
So I have to say that we are not competitors of hi-fi simulators. So we think that Califia is a great machine. We know a lot Eigenflow, and by the way, we collaborate with them, so we have a lot of discussions with them. Mm-hmm. So we are not competitors at all.
I understand that makes
should be done.
Yes, and that makes perfectly good sense to me. Forgive me, I didn't mean to interrupt you. But yes, I do understand you're not competitors, but collaborative. But there still is a value analysis that has to be done. We live in unfortunately a world of shrinking dollars and dollars worth less money. Those two things happen simultaneously.
So not all, especially for ECMO, not all hospitals and schools can have enough hi-fi simulators. So in this case, you can complement, or you cannot have enough hours of simulation. So you can train virtually and then you use the hi-fi simulator for a little time. So we can be a solution for those centers who cannot afford hi-fi simulators, or a complement for centers that can afford hi-fi simulators.
Sure.
About pricing, you can find that on our website. We have, so VSCPB, we launched VSCPB last 1 year ago, and we have been, it was a pilot test of the market, and we have since then been launching a new version every month. Now we launch a new version every three months, and each time we launch a new version, we try to put in the software all the enhancements that our customers have mentioned to us. So this is a live product, and this is also what we want to do. We are going at a big speed. We are going very fast because we want to introduce all what our customers say to us. And this is also our philosophy. These products will never be closed products, always open to all the improvements and changing in procedures that we find here and there. So if you are interested go to our web, ask for a quote. VSCPB is on the market, VirECMO is not on the market, and we're expecting to launch a first version this summer.
Very good. Yeah, we're definitely interested in both. I mean, I think this has a lot of viability. Juan, you have any suggestion, any ideas?
December, that's Christmas time. You can,
So y'all are going to bend. Y'all, is that what I'm going to get for Bosses Week? Am I going to get that present for Bosses Week? I like that. But yeah, that sounds it sounds very interesting. And I don't think I understood. You might have answered the question, and I just might not have understood you. But is there a way to experience this product before committing to buying it?
Sure. There is a demo available for everybody in the website. But if you are more interested for your center, then you ask us, and maybe we can facilitate a temporary license of use for you, so you can test and see if it works. And this is about VSCPB, but Marty, maybe you can explain about DEX.
Yeah, actually, as you can have the game, so you got, as Dana was saying right now, so you can test the demo, you can do the different tutorials. I think that there's like a couple of games that you can try before you just buy that. You can also buy that as an independent, so you don't have to be an institution. So anyone that wants the game just can be in the web, and you have the store there that you can buy the game. And then if you buy one of the games that we have, that right now is just only CPB, but it will be ECMO, the chatbot that we have already developed, it's included in the price that you are getting every month. Then you can also, if you don't want to play the game and you are only interested in DEX, in the chatbot, you can just buy that independently as well for your own proper use. And yeah, also you have to do it from the web. From the website is all the information that you need for buy it, and it's not very expensive. So
outstanding. So what do you think? What kind of time frame do you think you're looking at for the release of the ECMO the ECMO portion?
In summer, the first launch is foreseen for summer.
Summer, very good. Very good. Juan, any further questions?
Magic found you through the AMSECT meeting. Are you doing other perfusion meetings where you're going to be able to give us a little hands-on?
Actually, our marketing chief, Sarah Palanki, is gonna go this week to, I don't remember the name, to the conference.
Sunnybelt.
Yes, Sunnybelt.
Sanibel Symposium, yes.
Yeah. Sanibel Symposium, and we will be also at the Euro Perfusion Conference, which will be in Valencia in Spain this year.
Okay, I'm going there. What year? I'll just look it up.
In October.
In October?
In Valencia, nice place, good paellas, nice weather, wonderful beaches.
Perfect.
And wonderful perfusion, obviously.
Juan, I think we're on our way.
Let's go.
Let's go. We'll be there. We'll expect to see you and Marty together, and we'll put the glasses on and immerse ourselves in the virtual world of perfusion.
Yeah,
Sure.
actually, this is what I want to say, that you have to come. We invite you to come because actually we have all our products there. So you can try out the different products that we have in first person and with the glasses and all with the stuff. So we are bringing all for you.
Outstanding. Well, we can't thank you enough. This was very interesting, very different. This is way, this is really kind of going out there, in the world. But both Juan and I, maybe me more so than you, are towards the end of our careers, right? And we've seen things go from bubble oxygenators that had Brillo pads coated with Dow Corning anti-foam agent, all the way to where we are today with all of this very high technologically biocompatible stuff, right? And this revolution of information where we're now, talking about AI, even though I don't find AI to be intelligent at all, frankly. You may disagree, Marty, but that's just my view. I have strong views about it, but, I don't come from that generation, so it's very challenging for me. And I'm really trying to understand what works for the youth of today. And because those are who are going to replace us, right? And those are the people that I'm going to need should I need anything done to me. And I want them to be well trained. I want them to have all of the experience they can get before they're cut loose on the population and have to take care of myself or Juan.
The one thing that hasn't changed is the surgeon very forcefully instructing the person behind the pump. That's a constant, I think, for the last 40 years.
I would have just, you know what I would have done? I would have just said, you know what, do it yourself, and left. But I'm old. I can get away with that now. I couldn't when I was young. But anyway, with that said, it's a pleasure. I really enjoyed both of you. This has been a very interesting talk. I was a little I'm not sure what this is really about, but you guys did a great job at explaining it. And I highly recommend any colleagues that are watching if they're going to the Sanibel conference, to make sure they stop by your exhibit and see this product, the Vermex and Vermetics, like virtual medics, Vermetics, and go stop by there. And also, let's all go to Valencia and flood that whole city with a bunch of crazy Americans wanting to do virtual stuff, and we'll all have a lot of fun. But thank you again so very much. Good luck. Very interesting, very revolutionary, very forward-thinking, and I wish you all the best success. I'm looking forward to trying this out.
Muchas gracias.
Thank you very much.
Okay.
La mejor suerte.
Muchas gracias.
Gracias.
Bye. Ciao.
Bye-bye.
Bye.
Take care.
Okay. Well, with all of that said, that's our show for today. Our next program is not yet scheduled. The ECMO course is scheduled, but we have not yet decided what we are going to do for PerfWeb 100. I want to do something really special, different, unique. I just haven't thought of what that is yet.
Live from Valencia.
We did, us, live from Valencia. Let's get our wives, and we're going to meet in Valencia. And for those of you who don't know, Juan is married to Mindy, and Mindy is also a perfusionist, and we got a twofer. So we have both of them here in the Woodlands, North Houston area, joined our group here, and I have to tell you, it's been wonderful having you here. You, just before you had joined, Thomas had joined. We have Becky, of course, who you worked with for a long time. Melissa joined. And we have just got such a incredible team.
I know that there are folks in Virginia that are watching.
Yeah.
Courtney, I've made it to Houston. I know Mindy and Becky, who worked with us in Newport News, would both say hi. There's so many of you there that we love and we miss, and we hope you'll come out and visit with us in Houston and maybe give us a chance to convince you to come out.
Yeah, I was going to say, don't come out and visit. So if you miss them, have them come out here and be here, and then you wouldn't miss them anymore. So come on, let's go. Come on, let's go. You know what? You can reach me. Look, you can find me anywhere. Just call me. All right, call Juan. Have him. He'll give you my number. Call. Let's make it happen. All right. We're looking forward to you starting soon. Start getting your Texas license now, though. It takes a while.
It takes a while.
It takes just a little while. All right. We'll make the announcement for PerfWeb 100 in the next few days. Oh, we have 2 more days of this program. Yeah, that's right. So tomorrow, what am I doing tomorrow? I forgot. Tomorrow, you have it? You can put it up? Here, I can just tell them. I can just look it up. Oh, yeah, tomorrow is going to be kind of fun. It's going to be Z-Buff and what fluid works best for Z-Buff, and because a lot of people use saline, but we're going to talk a lot about that. So if you have hyperkalemia, which fluid works best? And then we're going to be in the afternoon, I'm going to have an ECMO pump. I'm going to have a CRRT machine. We're going to have all the cameras on all the different pressures and flows, and we're going to talk about how you integrate the CRRT machine into the ECMO circuit and make it work. But what does it do? Because all of it's a closed loop, and all of it is going to interact with each other, from the patient to the ECMO to the CRRT machine, and in a big loop. Everything has an effect on everything else. How do you make it work correctly? Because your CRT machine can be ineffective, but it can also be effective if you set it up properly and understand what the pressure flow relationships are and how it affects each of those different components. So we're going to be doing that. And then on Wednesday, I'll be finishing up with my near misses. Now, I don't know if you have any near misses. I have 3 absolute near misses. 4th one, if you want to count one that's kind of half and half.
I mean, a near miss is a hit.
A near miss is what it really comes down to is I'm going to talk about 3 times where, despite my best efforts to the contrary, the patient not only survived, but did just fine when they really shouldn't have.
All right.
They really shouldn't have.
So I guess that is a near miss.
It's a near miss. It's just like, and I got a really cool video on it. It's just like being a sniper in a sniper's nest and deciding that you need to grab something to eat or drink or take a leak, and moving from that position is just as you move, the bullet goes past where you were and hits the wall behind you.
Well,
it's that close.
That sounds like, a story that a lot of folks would benefit from hearing.
It's the 3 real near misses.
I heard about PerfWeb from my colleague Courtney in Newport News, and I'm sure you folks have friends that may not have heard about the programming here. It is good for CEU. You can save some money and join us on the web.
Earn them all. Earn all your CEUs right here.
Let your friends and neighbors know.
And then instead of going to a conference on vacation and walking in, signing in, and leaving to go to the beach, okay, and feeling guilty the whole time you're doing it, you can just, maybe.
Guilty.
Well, instead, you could just go on vacation and actually just go on vacation with your family. Okay? I mean, the reality is employers are paying less and less and less and less.
They are.
Conferences are getting more and more and more expensive, and they're not always where I want to be. So this is how this all got started. And then COVID. because COVID, people weren't going anywhere. People still needed CEUs. That's what sort of started this whole thing. All right. See you tomorrow.
Thanks for joining us.
0800 ZBuff. Peace out.